What is acute pancreatitis? Acute pancreatitis is basically an acute inflammatory process, usually painful and self-limited. It can be an isolated event or a recurrent illness, and most of the time the pancreatic function and the morphology returns to normal after arbitrary attacks. So it's an inflammatory process. If you see the etiological diagnosis of the acute pancreatitis, you can see here 45% are secondary to gallstones and 35% are secondary to alcohol abuse. So 80% of the cases are secondary to these two conditions, while 10% are idiopathic and 10% due to other causes. So what are those 10% other causes? So you can see over here that after cholelithiasis, ethanol abuse and idiopathic, we have a list of the causes which can cause the 10% of the cases of the acute pancreatitis, like medications, hyperlipidemia, surgical procedures like ERCP, trauma, pancreatic tavism, hereditary pancreatitis, hypercalcemia, viral infections like mumps and coccidiosis virus infection, end-stage renal failure, or the penetrating peptic ulcer, which is basically the local effect, local issue. So in the medicines ward, usually we get the reasons like patients who have developed the acute pancreatitis, they can do some medications, those who have a high triglyceride levels, are those who have a high calcium due to any condition, any reason, and viral infection. So these are the commonest causes of the acute pancreatitis which are admitted in medicines ward after this ethanol abscess and cholelithiasis. Just look at the normal anatomy of the pancreas. This leaf-like structure is pancreas. You just see the adjacent structures, like this is liver, this is gallbladder, and this is the cup of the duodenum where the pancreas is residing. So the ducts from gallbladder drains here in the common bile duct. The hepatic ducts also drain into the common bile duct, and the pancreatic duct also drains into the common bile duct. So this common bile duct basically drains into the duodenum by an orifice which is called as an ampulla of the Vater, and which has a sphincter which is known as an sphincter of Oddi. So this is the normal anatomy of a pancreas. So any trauma or any local issues related to gallbladder, like gallstone slips from here, from the gallbladder duct to common bile duct and come here to the ampulla of Vater, can block the pancreatic duct over here. Or there can be a penetrating ulcer in the duodenum which can affect the pancreas, or the liver conditions like hepatitis or anything which is causing the inflammation and edema in the retroperitoneal space can cause the pancreatitis. Well, when you are considering the physiology of the pancreas, you can see that pancreas has a dual function. It has an endocrine function, it has an exocrine function. The cells of the endocrine functions are known as islets of the Langerhans. They release the insulin, glucagon, and somatostatin, and all these things basically helps in the regulation of the blood glucose. While the exocrine part of the pancreas has the cells which are called as acini, they have different enzymes like protease, lipase, amylase, and they all basically digest the food. So the main issue which causes the acute pancreatitis is related to this exocrine pancreas and those cells which are called as acini. This is a list of digestive enzymes which can be produced by the pancreas acinar cell. You can go through this list, but the two important enzymes which I highlighted in the red are basically amylase and lipase. They help you in the diagnosis of the acute pancreatitis. These all enzymes are basically for the digestion of the different food types. So basically what happens, why the acute pancreatitis occurs? There are three mechanisms. One is the duct obstruction. Duct means pancreatic duct obstruction. So the main reasons are again the cholelithiasis, a slip gallstone which goes to the common bile duct and it has blocked at the ampulla of the Vater. chronic alcoholism, which causes the ductal concretions and causes the damage, obstruction. All these things, when there's a duct obstruction, basically causes the interstitial edema of the pancreas. It will impair the blood flow of the pancreas and it will cause the ischemia, and this ischemia will lead to the SNR cell injury at the result. Second mechanism is direct SNR cell injury, like in the cases we have discussed, viral infections, mumps, alcohol intoxicity itself can cause the SNR cells, drugs or ischemia because of any reason. They basically leads to the they release of the intracellular proenzymes and the lysosomal hydrolases, and it activates the enzymes and it causes the SSR cell injury. The third is the defective intracellular transport. So whenever there's a metabolic injury or there's a duct obstruction, it can itself directly affect the intracellular transport system, and at the result it can also lead to the SNR cell injury. So whenever there is a SNR cell injury, it activates the enzymes. So we know there's a list of the enzymes we have seen in the previous slide. They have a different functions. They hydrolyze the different food particles, so they causes the damage to the pancreas. It causes the interstitial inflammation and edema. It can causes the proteolysis, fat necrosis and hemorrhage in the pancreas, and this ultimately leads to the acute pancreatitis. Well, severity of the pancreas, we have 3 stages which will suggest that how much severe the pancreatitis is. At the stage 1, there's a pancreatic injury that we have discussed. There's edema, inflammation, there's a hemorrhage in the pancreas. This is the stage 1. When this pancreatitis affects the local areas that we have discussed in the anatomy, like there was a peritoneal region, there was a pancreas, there was a duodenum, there was other structures surrounding the pancreas are affected, then that will be considered as a stage 2, like the retroperitoneal edema and the ileus. Stage 3, when those enzymes of pancreas are released into the systemic circulation and they cause the shock, hypertension, metabolic disturbances, sepsis, and ultimately the multiple organ failure. So this will be considered as the stage 3 will be considered as a severe acute pancreatitis. Here is just a graph that will be telling us that most of the patient present in ER at the 12 hours of presentation of the abdominal pain, and the organ failure, the peak of the organ failure occurs at 72 hours. Means most of the patients who have a severe acute pancreatitis can go into multi-organ failure between 48 hours to 72 hours. So how the patient with the acute pancreatitis clinically present? The typical presentation is abdominal pain, nausea, vomiting and fever. What are the characteristics of the abdominal pain? Patients typically have epigastric pain. This epigastric pain radiates to the back of the patient. It worsens when patient is in the supine position. So most of the patients with the acute pancreatitis basically try to sit and lean forward to improve their pain. Because of the inflammation, they can develop the fever. So when you do the general physical examination of a patient, first thing you see the appearance. The patient can be well with a mild acute pancreatitis. It can be gravely ill with profound shock, toxicity and confusion in the cases of severe acute pancreatitis. The second thing you do is basically vitals, and many patients are tachypneic, they have a tachycardia, there can be possibility of hypotension in the severe acute pancreatitis. There are possibility in the 76% of the cases they will be having a high temperature, but temperature can be normal, temperature can be low, especially in the cases when they have a multi-organ failure. The third important thing on the examination is like there is the jaundice, which is present in 28% of the patients. Basically, this occurs in a gallstone pancreatitis or due to the edema of the pancreatic head. Overall, patient can have a pallor, cold, clammy skin, diaphoresis and dehydration when the patients have a severe acute pancreatitis. 10 to 20% of the patients can have a chest findings, like most of them have a left pleural effusion. They can have a pulmonary crepitations or a delactasis. When you do abdominal examination, there will be a rigidity, tenderness in the epigastric region. There's a possibility the bowel sounds are diminished or absent on auscultation. When you palpate the epigastric region, there can be a palpated pseudocyst, which is a complication of acute pancreatitis. If the pancreatitis is very severe and necrotizing, then there are possibility you will get the colon sign, Turner sign, or the Fox sign. What are these signs? I'll show you the pictures. See, this is the colon sign. There is a purplish bluish discoloration. Basically, this is a hemorrhagic kind of purpura which is present around the umbilicus. This will be considered as a colon sign. When this purplish grayish discoloration is present in the flank region, then it will be called as a gray Turner sign. And Fox sign is when this purplish discoloration is present below the inguinal ligament. It is considered as a Fox sign. These all signs are basically telling us there is a severe necrotizing pancreatitis has occurred. So how we diagnose the patient? There are 3 criteria, 2 out of them, 3 needed for the confirmation of the diagnosis. Typical abdominal pain that we have discussed is an epigastric pain which radiates towards the back and which improves on leaning forward. And if you go through the investigation, serum amylase or serum lipase, which are greater than 3 times the upper limit of the normal, and the characteristic findings on the abdominal imaging. So if you will get first 2 things present, like a patient has a typical abdominal pain that is related to acute pancreatitis and their amylase or lipase are raised, then you will label this case as acute pancreatitis. But if any one of them is missing, then you should go for the abdominal imaging in the case of ultrasound abdomen and the CT scan abdomen. Then after diagnosis of the acute pancreatitis, you need to know what is the etiological diagnosis, why the acute pancreatitis has occurred. The things that will help you in the etiological diagnosis, one is the history, whether the patient is taking alcohol, patient is having trauma, or patient is taking any typical medication that is causing the acute pancreatitis. Or on the ultrasound, patient will get the ultrasound. On the ultrasound, the patient is having gallstones or he has abnormal LFTs. Or on the lipid profile, there is a triglyceride level which is more than 1000. The hypertriglyceridemia is there. Or hypercalcemia, there's elevated calcium levels. So these will help you in the diagnosis of the reason behind the acute pancreatitis. After diagnosing, we decide how much severe is the pancreatitis. So there are the predictors which will tell us how much severe this acute pancreatitis can be. Why are they needed? Because we need the appropriate patient triage therapy. It compares the results of the studies of the impact of the therapy. We will be able to decide what kind of therapy should be given to these patients. When are they needed? That should be done within the 24 hours of presentation of the patient, because the damage occurs early. Which is best? There are so many scales which are available. You can see so many things in the books, and different criteria are used in different countries. Here I have shared a commonly used criteria which is called the Renson's criteria for pancreatitis. It is assessed at the time of admission and within 48 hours of the admission. So if the gallstones are there, then the criteria slightly change, which is given here in the below part. You don't need to remember all the things, but you will need to know this list when an acute pancreatitis patient is present in your ward. So there are different things. Each carries one point. Like a patient who is more than 55 years of age present with a severe abdominal pain and his glucose level is more than 200, and suppose his AST level is more than 250. It means this patient will carry 3 points. And you can see here is a scale given with the numbers. Like this calculated numbers for a patient was 3. So 0 to 3. Associated mortality rate is 1%. It means it's a mild acute pancreatitis, and there are less chances the patient will there will be a death of the patient. But suppose a patient who scores more than 7 points. Suppose the patient is more than 55 years of the age, his WBCs are more than 16,000, glucose is more than 200, LDH is raised, AST is raised, then his hematocrit fall at the 48 hours is more than 10%, his calcium is less than 8%. Suppose these are 7 or more than 7 numbers, patient on the calculation the number is more than 7, then the 100% mortality can occur. So Renson's criteria is basically used to predict the mortality in the acute pancreatitis. Acute pancreatitis is an emergency. So how we treat the cases of acute pancreatitis? The aim is limit the systemic injury by support and resuscitation, prevent the necrosis of the pancreas by early feeding, prevent the infection by giving the antibiotics, which is basically imipenem and the ciprofloxacin, if the necrotic pancreatitis has occurred. Otherwise, there is no role of antibiotic. When a patient is having mild pancreatitis, they need to be given the pancreatic rest. Means they should be kept NPO. There is no parolar intake of the food or the liquids. They will be given the supportive care like fluid resuscitation will be given, blood pressure will be checked, urine output will be checked, pain control should be maximum, and they should be refeed after 48 hours or within the 48 hours if the bowel sounds are present, if the patient is hungry, if he is pain-free. In the cases of the severe pancreatitis, again the pancreatic rest and the supportive care is given, fluid resuscitation is done. Usually these patients need 5 to 10 liters per day. Careful pulmonary renal monitoring should be done. They should be admitted in ICU. They maintain the hematocrit of 26 to 30%. Pain should be properly controlled with the IV narcotics. Correct the electrolyte derangements if present, like potassium hypokalemia, hypercalcemia. The magnesium levels should be checked and corrected. Rule out the necrosis. After 48 to 72 hours, contrast CT scan should be done to find out whether the necrosis of pancreas is present or not. If there is a necrosis of the pancreas present, then you should go with antibiotics or the surgical debridement can be done. A good nutritional support should be given to the all acute pancreatitis patient. It will improve the morbidity and mortality. Is there any role of surgery in these patients? Yes. Those patients who have gallstones, they have a mild disease, the cholecystectomy should be performed before the discharge. If the patient has gallstone and patient has a necrotizing acute pancreatitis, then the cholecystectomy can be delayed and can be done after the necrosis is improved. If as a complication pseudocyst has developed, if it is asymptomatic, then there is no need of drainage, but if it is symptomatic, the drainage, surgical drainage of the cyst will be required. Drainage of the infected necrosis should be delayed for at least 4 weeks to allow the formation of the wall of necrosis. So that drainage is basically required after the 4 weeks, not before that. So at the end, what was basically acute pancreatitis? In most of the cases, it is a mild self-limiting disease. Gallstones and alcohols are the leading causes, means 80% of the patients that present with acute pancreatitis are secondary to these conditions. Early and accurate diagnosis is crucial. It is an emergency, so diagnosis should be timely sought out. Early treatment, it's an emergency. Early treatment with aggressive eye fluid hydration saves the lives and is most beneficial in the first 12 to 24 hours. So treatment should not be delayed in any case. Routine prophylactic antibiotic use is not recommended unless the presence of the infective necrosis established clinically by the FNN. Mild acute pancreatitis due to the gallstone warrants the cholecystectomy before the discharge. So if it is a mild pancreatitis, you should go for the cholecystectomy before the discharge.